part two, because last year I presented when we just signed up with Vitro, and we're planning our project, so this is 12 months on. So who are we? We are a private hospital. We're in Christchurch. We sort of sit around, 86 beds. We've got ICU and HD, high dependency care, maternity primary birthing unit. We also have, as well as the other day units, a joint venture with Cancer Care and Eye Care. So we went into this with the challenge that we're all facing, is that we wanted to be digital, and we wanted to have a digital medical record that would improve our patients' experience and our clinicians and our employees' experience, and be able to contribute to the continuous quality improvement process. So we wanted to be able to get data out of it and analytics, and we had some really key considerations, some of it because we're a private hospital, so we have about 150 surgeons or anaesthetists that don't work for our hospital but bring their patients to us. So they all bring their own and thoughts about what we should do around documentation. Our own resources, so a reasonably small hospital, and how we could manage such a big project and implement something with the small team that we had. Our clinicians that don't work with us exclusively also work with a lot of other information systems, so expecting them to come along and have something different, we can't all afford the same thing, and we can't all the same product's not going to work. So we really thought about that someone that might only have a list once every 6 weeks could come in and pick it up and not feel like he didn't know what he's doing, or she didn't know what she was doing. I put down the bottom, clinicians don't like change. When I talk about clinicians, I mean all clinical staff, and I don't actually believe that. I think we're changing all the time, and it's just what the change is and how it's implemented is usually the issue. So the solution, we ended up choosing Vitro Software. The reason why we went down this track was because we could make it familiar to us and what we were used to. And it would be based around our work processes, and we could get the reportable, meaningful digital information and their analytics. Our approach, we didn't go big bang. We knew we didn't have enough people to go big bang, and we wanted to really make sure it was working for us as we worked through the process. So our first phase was the end-of-bed chart. We had other success criteria sitting next to the remote access straight away for our surgeons and anaesthetists that don't work on site, and our integration design. Obviously, we weren't looking for a new patient management system, but we chose not to use them for the EMR. So we wanted to make sure it did work together, and also around device selection and things like single sign-on that we implemented at the same time. The reason we went with the end-of-bed chart was because we wanted to start with something that we knew, and as the clinical lead that I knew, so this was my background where I came from, ward nursing. It also gives us, this is often what the first thing we want to look at when we're seeing if our patient's okay, is that end-of-bed chart. That's why it sits at the end of the bed. It's that quick reference. So we went with that, and obviously just with the integration design that we weren't duplicating any information. Our approach, so this is very clinician-led or clinically led. We've actually gone through 3 different leaders in the IT department in the time that since I was here last at HiNZ. So if you think about that, the fact that we've managed to go live is because clinical staff were leading it and not other areas. We started with clinical workshops, so pulled all that paper that comes from everywhere, and you never know how much paper's out there that you thought you had a really good document management process. You haven't, and they need every little single bit of it. So we had to pull all that information together and see how it all works together. We had lots of different nurses, mainly from our wards, that came through, so from new grads to senior staff, and just got out the butcher paper and started looking at the work processes around how we document. and then had to make the decisions. What do we keep? What do we change and improve? We just didn't want to, we weren't turning paper into digital or putting a form behind a glass screen, as someone said to me. We actually wanted to improve it, but keep the simplicity of what we know well in our work processes. The next step from our own internal clinical workshops was workshopping with Vitro, and we brought in the same clinical staff to do that, and some others. And then sign off our requirements, get our product back and test, which is the hard bit, I would say. But we actually, so we had our really strict test scripts, but we actually also gave it to a lot of those staff involved in those workshops and said, just play in there. And they were the ones that usually could pick up, you know, where there were things, little nuances that we hadn't thought of. Our training journey has been, you know, an interesting one. We started with 2-hour sessions. Found it really hard to get clinical staff released from full 2-hour sessions. So, and then found that we didn't need 2-hour sessions. We needed to teach people how to get around the system. But once they did that, they just needed to have a go. So just giving them all access whenever they could to the UAT site meant that they could figure it out for themselves. We also have, we haven't really defined the super users because we didn't know who were going to be our best super users. So we brought in the people we thought would be to start off with, and they got the training. And then other people were just sort of self-nominating as super users and, oh, I know how to do that, I'll come and give you a hand. And so that's worked really well. We've gone live on one ward. So at the moment, so 4 weeks in, we're just starting to redeploy other staff into that ward so that as soon as we go live to the next wards, they're ready to go. It's just a little video of something that we designed with Vitro. It's our doctor's summary, so they get their notes. It's gone really fast now, it didn't seem that fast. So they can flick through their end of bed chart really fast. This is a nurse entering her vital signs. We're using a touch screen at this point. That's why you can't see a little cursor around. And this is actually real time in how quickly you can get around. Using a national early warning score system. And then we get our pop-up onto our OBS chart, and we have to navigate out of that pop-up before we can go away. Back to the doctor's summary. So this is integration. He's only seen his patients. If you want to, you can flick through the whole chart. So it looks like they can find things, but we want to be able to navigate quite quickly. These templates are our templates, so based on what we had on paper, but with the smarts behind them. So and then that brings us back to our doctor's summary. Device selection was really important to us, and we started that with clinical workshops as well. There was assumptions that we would just get computers on wheels and that was going to work for everybody, and all these products arrived to have a look at. And when we workshop with the nurses, what their biggest concern about going electronic was that they would have a device between themselves and the patient, and they didn't want that. And when we also went and we obviously did hospital visits, we noticed that the devices, the computers on wheels, weren't going into the patient room, so they were transcribing onto a piece of paper, which we wanted to avoid at all costs, and just going out and putting it in. Infection prevention and control. So we went for the bedside device, so we got fixed bedside devices. Means that they're not taking something from room to room, so you're mitigating that risk of spreading things. Health and safety as well, we're not pulling something around. There are things that we knew that they would need a keyboard for, so our admission process. So our nurses on the bottom are using the Surface Go, which is what we went with, so they can use it as a tablet if they wish to, and then use the keyboard. So this was our first day of go live, and I came in and they were just finishing up their admission paperwork, and I said, you know, you can use the big device just behind you. And they said, oh no, we're just having fun, we're fine here. So they just fit into the pocket. So we thought that's quite handy if you need to put it down quickly, but the idea is that they're not carrying them around all the time. It's for specific things, and they also won't take them home with them if they're big and bulky in the pocket. So, have we achieved what we set out to do? We've got a little happy dance up in the corner. We're very early on, like I said, in the 4th week of life. I was able to come away for the week though, and nothing's happened, so that's always a good sign. Actually, some pretty cool things have happened. So, from have we improved patient safety and experience? I had a nurse, the charge nurse of the ward, very excited when I arrived one day at work that was saying, "You'll never guess what's happened." And I was like, "Oh God, what?" And she said, the surgeon who'd just been onboarded the day before had looked up his medical records at home before he came in for his ward round, so they had no access to this before. He had noticed something, he must have had some suspicions, he'd noticed something about the pain score, and it wasn't that it was bad, it just hadn't got better. And so he'd noticed something, so rang the ward and asked for some investigations to be done. By the time he came in for his ward round, the investigations were done, they were all fine, and the patient went home as normal at the normal expected time. It wasn't delayed, and then it wasn't delayed for the surgeons have to follow that up later, those investigations. So we're pretty happy with that. We think that's a really key, anecdote that we can say, yeah, we've achieved something. And these are from our nurses, some of our nurses that have what their feedback has been. So we've had a really good positive uptake from the nursing staff. And I do have anaesthetist messaging me today, "Hey Erin, I'm just downloading the app. Can you give me the login?" So, and things like that. So they're engaged, which is a really good thing for us, because being private, sometimes that's a really hard thing. They didn't need a lot of training. We did the onboarding, we got them their single sign-on. They love that they can walk in the room and just tap on, and it opens up the system, and the patient's still there. So still not better than paper though, so good to know. So I'm probably running really close to time, but just the lessons we learned, and I've kind of touched on them. It's a really, really big job, and we're a really small team, so we need some more people. We'll be getting some more people. Put the patient at the centre of decision making. So people do come, like when you hear a whole lot of health professionals sitting in a room saying what we need to do and what needs to happen, if you bring it back to, I always find if you bring it back to how will this impact on the patient's care, you can usually come to what's going to be the best thing for the product. Communicate when you think you've done enough, you haven't, and communicate up as well. So keeping it at board level constantly, the project, to make sure we maintained our momentum and had that support from our senior level. I sit in on the senior clinical committees, so we're always discussing them. Be prepared to change your mind. I had different ideas at the start at what it would look like. We all have our own bias, but I'm pretty happy now. Just the way it's been taken up, there's not much that I'll do differently at this point. And just keep it simple. We had to be realistic about what we could achieve with who we had and, the budget we had. But make sure you're making it smarter. And what's next? So we're rolling out the bedside devices to the rest of the wards, dropping the integrated notes in the next couple of weeks, and pathways to our initial rollout group, finalising our medication chart and the remaining phase 1 charts, and then begin workshops phase 2. So, any questions?
Thank you very much.